All right. So I'll be talking about disparities in postpartum care after a hypertensive disorder of pregnancy in the US. Let's see. First, I want to thank Marcia and the organizers of the Women's Health Forum for the opportunity to speak today. And I want to thank my co-authors on this project who are listed here and span cardiology, maternal fetal medicine, and biostatistics. And I'm going to be presenting some data from the Pregnancy Risk Assessment Monitoring System, or PRAM. So I want to thank the PRAM survey participants and the PRAM sites who make this unique data set possible. This way. Okay, so here are my disclosures. And so first, I'll just briefly talk about the long-term cardiovascular effects of hypertensive disorders of pregnancy, but both Nisha and Virginia have already spoken about this, so I'll be brief. And then I'll talk about current recommendations for postpartum care for these patients. And then I'll share data from PRAMs about postpartum care for patients who've had hypertensive disorders of pregnancy, and then talk about some opportunities for improvement. So high blood pressure in pregnancy is very common, complicating more than 10% of pregnancies in the US. And it's associated with a lot of postpartum mortality and morbidity. It's one of the most common reasons for postpartum hospitalization. And more than a third of these patients will go on to develop chronic hypertension within 7 years of the delivery. And they have an increased risk of coronary artery disease, stroke, and heart failure. And there are also striking disparities in both the prevalence of hypertensive disorders of pregnancy and the outcomes for these patients. Black women and Native American women are more likely to have preeclampsia in pregnancy. Black, Hispanic, Asian, and Pacific Islander women with preeclampsia have higher in-hospital mortality. And Black women with preeclampsia are also more likely to have a postpartum hospitalization. So the postpartum visit is a really important opportunity for these patients. It's an opportunity to do postpartum blood pressure monitoring and titrate medications, but it's also an opportunity to provide patients with education about their long-term cardiovascular risk and screen for modifiable cardiovascular risk factors, provide counseling on lifestyle modification, and ensure linkage to longitudinal care. And I didn't put it here, but Nisha's presentation reminded me it's also an important touch point before any future pregnancies, and you have the opportunity to improve health before a subsequent pregnancy. So for these reasons, both obstetric and cardiology professional societies recommend a postpartum cardiovascular risk assessment and counseling for patients who've had a hypertensive disorder of pregnancy. So this was a scientific statement from the American Heart Association describing opportunities in the postpartum period to reduce cardiovascular risk after an adverse pregnancy outcome. And they highlight the need for cardiovascular screening and counseling and suggest using Life's Essential 8 as a potential framework, looking at both cardiovascular risk behaviors like smoking, sleep, diet, and exercise, as well as cardiovascular factors like blood pressure, cholesterol, weight, and blood glucose. And this was from a toolkit released by the American College of Cardiology about postpartum hypertension clinic development that recommends that in the early postpartum period, the focus be on blood pressure management, but in later postpartum visits that they also cover lifestyle counseling, cardiovascular risk assessment, and that transition to primary care. And some of the specific postpartum clinic activities that they highlight is measuring weight and blood pressure, assessing mental health, doing blood testing to check for other cardiovascular risk factors, referring patients as needed to nutrition and weight loss services, estimating their 10-year or 30-year or lifetime cardiovascular risk, and providing counseling. And then similarly, the American College of Obstetricians and Gynecologists recommend that in the postpartum period, patients have an initial blood pressure check, and then by the time that they reach 12 weeks, that they've had a comprehensive postpartum visit that includes a comprehensive assessment of their physical, social, and psychological health. And that for patients who have hypertensive disorders of pregnancy, that this includes a baseline cardiovascular risk assessment and counseling. So how well are we doing in implementing these guidelines? Well, prior research has shown that despite the critical importance of postpartum care for patients with hypertensive disorders of pregnancy, they have pretty suboptimal rates of postpartum follow-up. So recent studies have shown rates of about 79%, and earlier studies have shown even lower rates of postpartum follow-up in this patient population. And many of these studies have documented disparities by race, ethnicity, and socioeconomic status. And as well, they found that overall, there are generally pretty low rates of postpartum counseling about healthy lifestyle and weight in the general population presenting for postpartum care. But some of these prior studies have had limitations. So some have used data from a single institution or state, or used data from national commercial insurance claims. So individuals who are uninsured or receive Medicaid or have changing insurance status are likely underrepresented. And differences by rural versus urban residents have not been as well studied. And then there's been less research on the components of postpartum care and counseling received by individuals with hypertensive disorders. So we use data from the Pregnancy Risk Assessment Monitoring System, or PRAMS. This is a nationally representative US population-based survey of postpartum women who've had live births. It covers 46 states and represents more than 80% of all live births in the US. And individuals are surveyed 2 to 6 months after the delivery. And we analyzed data from 2016 to 2022. And our objectives were among women who had a self-reported history of a hypertensive disorder of pregnancy to assess their postpartum visit attendance, assess the components of postpartum counseling and screening related to cardiovascular risk that they received, and then compare these outcomes across sociodemographic characteristics. And so we included individuals who had self-reported a history of hypertensive disorder of pregnancy, and we did include chronic hypertension in our definition. So we define this as answering yes to at least one of two questions. During the 3 months before you got pregnant with your new baby, did you have any of the following conditions, high blood pressure or hypertension? And during your most recent pregnancy, did you have any of the following conditions, high blood pressure that started during this pregnancy, preeclampsia or eclampsia? And then our study outcomes were 1, attending a postpartum visit, which was assessed with a survey question, since your new baby was born, have you had a postpartum checkup for yourself? And then we secondarily looked at the components of postpartum counseling and care they received related to cardiovascular risk. So participants who reported attending a postpartum visit were then asked, did a healthcare worker do any of the following things at your postpartum checkup? And we focused on the 3 questions that were most related to cardiovascular risk. So talking about healthy eating, exercise, and losing weight, asking about smoking cigarettes, and testing for diabetes. And then we also looked at other components of postpartum care, including screening for postpartum depression and counseling about contraception. And then our multivariate analyses adjusted for sociodemographic characteristics, comorbidities like chronic hypertension and other pre-pregnancy cardiovascular risk factors, as well as pregnancy and delivery characteristics like parity, delivery mode, and postpartum depression. So there were over 47,000 participants with hypertensive disorders of pregnancy included in the analysis, and these are some of the demographic characteristics. So more than half were between the ages of 25 to 34 years old. There were 3% Asian, 20% Black, 68% white, and 13% Hispanic individuals represented. 17% lived in rural areas. 63% had at least some college education. 52% had private insurance, and 43% had Medicaid. And then these are some of the clinical characteristics of those included. So 13% had diabetes, 17% had gestational diabetes, about a third had chronic hypertension, there were high rates of obesity and pre-pregnancy tobacco use, and 18% had preterm birth. So we found that among individuals who reported a history of a hypertensive disorder of pregnancy, 90% reported attending a postpartum visit. We did find that there were disparities by race, ethnicity, and social factors in postpartum visit attendance. So this is from our multivariate analysis. So adjusting for other clinical and social factors, we found that Hispanic, non-Hispanic Black, and individuals of other multiple races were less likely to attend a postpartum visit compared to those who are non-Hispanic white. And then we also found that individuals with lower educational attainment, lower income, and those who were uninsured or receiving Medicaid were also less likely to report attending a postpartum visit. And this was, again, in our adjusted analyses. In the unadjusted analyses, we also found that those living in rural areas were less likely to attend a postpartum visit, but this difference did not persist in the adjusted analyses. And then looking at the specific components of the postpartum care that they received. So this was among individuals with a hypertensive disorder of pregnancy who reported attending a postpartum visit. Only 61% reported receiving screening for smoking. Only 56% reported receiving counseling about healthy lifestyle, and only 24% reported receiving testing for diabetes. The testing for diabetes was higher among those who also had a history of gestational diabetes. It was 52%. But this was in contrast to other types of postpartum care. So postpartum depression screening and contraceptive counseling were almost 90%. And then when we looked at the components of postpartum counseling and care received, we did find that there were differences by race and ethnicity for those counseling and care services that were most related to cardiovascular risk. So these figures show our adjusted odds ratios, looking by race and ethnicity. So looking at Asian, Hispanic, non-Hispanic, Black, and individuals of other or multiple races compared to non-Hispanic white individuals. We found that non-Hispanic white individuals were less likely to receive healthy lifestyle counseling, screening for smoking, and testing for diabetes. And this was adjusted for other clinical and demographic characteristics. And then this was in contrast to other types of postpartum care. In our unadjusted analyses, we found that non-Hispanic white women were more likely to receive contraceptive counseling and postpartum depression screening. But then in the adjusted analyses, we found that there were no differences for contraceptive counseling and postpartum depression screening. So I think there are several takeaways as we think about opportunities to improve postpartum care after a hypertensive disorder of pregnancy. So among individuals with a reported history of a hypertensive disorder, the self-reported postpartum visit attendance rate was actually pretty high, but there were significant disparities by race, ethnicity, and social factors, similar to what's been seen in national analyses of commercial insurance data. And then postpartum screening for depression and contraceptive counseling were common in this population, but counseling and screening for cardiovascular risk factors was overall low, despite the fact that we know that these individuals with hypertensive disorders of pregnancy are at higher lifetime risk of cardiovascular disease. And then there were significant differences by race and ethnicity in the components of postpartum care received by individuals with hypertensive disorders of pregnancy, with the exception of contraceptive counseling and screening for postpartum depression. So overall, we found that a high proportion of individuals in PRAMs who'd had a hypertensive disorder of pregnancy reported attending a postpartum visit, higher than what's been seen in national analyses using commercial insurance claims data. I think there's several potential reasons for this. One is that PRAMs is self-report survey data, and those who respond to the survey may differ from those who did not respond. There's also the potential for recall and social desirability bias. And then prior studies have found that self-reported history of hypertensive disorder of pregnancy is specific but not sensitive. So we may have missed individuals who have hypertensive disorders of pregnancy, perhaps those with less severe disease. Then on the other hand, there are limitations of the prior studies that have used commercial insurance claims data, which may underestimate postpartum visit attendance. If individuals have changes in their insurance status across the perinatal period, or if postpartum care is billed using bundled service codes, then we may underestimate the postpartum visit attendance. And then finally, there's differing definitions of hypertensive disorders of pregnancy across studies. So some studies have just focused on preeclampsia. We included chronic hypertension in our definition, which might influence follow-up. Though in our sensitivity analysis, we excluded those with chronic hypertension and did not find a major difference in our results. And then we did find that individuals from racial and ethnic minority groups were more likely to receive screening for cardiovascular risk factors and counseling about this. And there's several potential reasons for this. It may reflect implicit bias or assumption about healthcare behaviors and healthcare needs, or awareness by clinicians about worse peripartum outcomes and barriers to care among these groups. So where do we go from here? I think we need increased awareness and education for both patients and the clinicians who care for them in the postpartum period. We need research to understand the barriers to providing cardiovascular risk assessment and counseling in the postpartum period. And some institutions have developed comprehensive postpartum hypertension clinics that do a comprehensive cardiovascular risk screening and counseling and bridge to primary care. And then we did find that the components of postpartum care that specifically postpartum depression and contraceptive counseling, which are included in national quality metrics, had higher rates of completion. And so perhaps postpartum cardiovascular counseling and care could be considered in quality metrics for those who are at higher cardiovascular risk. There are a number of limitations with the analysis. So in addition to the fact that it was survey data based on self-report, we also had small numbers for certain racial groups, and that limited our ability to analyze with more detail. We were missing data on some of the sociodemographic characteristics, and then we lacked data on social determinants of health. We also did analyze years that included the COVID pandemic, though when we excluded those years in our sensitivity analysis, there was no major difference in our findings. And then the phase of PRAMs that we used lacked data on other postpartum counseling and screening that might be relevant to cardiovascular disease, specifically lipid screening, postpartum home blood pressure monitoring, and counseling on the long-term cardiovascular effects of hypertensive disorders of pregnancy. And then finally, there were no questions about the barriers to providing this cardiovascular screening and counseling, which remains a gap. And then there were several strengths. So this was a large nationally representative population-based survey, and we were able to look at potential differences between rural versus urban residents. And then importantly, we were able to adjust for other clinical and pregnancy characteristics that aren't well captured in claims-based data. And then finally, we were able to analyze the specific components of postpartum counseling and screening related to cardiovascular risk among individuals with hypertensive disorders of pregnancy who we know are at increased lifetime risk. And I think we've highlighted some areas for improvement. So again, I want to thank my co-authors on this project and the PRAMS participants and PRAMS sites. And here are my references. Thank you.